There we go. Welcome. Thank you so much for being here. I'm so glad to be talking to the people with the feet on the ground for the vulnerable population of elders that we're talking about. And I'm excited to talk to you about a passionate area of mine, which is medication issues. But before I start on that, I want to give a big thanks to our sponsors for this program, Catholic Charities of Hawaii, Circle for Care for Dementia, Hale Kuike, and the Administration for Community Living. So I'm really glad to be talking to this group. I love talking to nurses and caregivers of patients, older adults, regardless of whether it's dementia or something else. And I will have time for questions at the end in the chat box. Jody will be helping with that. I also want to start by saying that this is a huge topic in geriatrics, and we really can't cover everything. So I really selected some of the key groups of medications that are problematic in older adults. And I'm sure that if they have questions about other things, we can possibly address that in the end. This is based on evidence from the Beers criteria, and we'll talk about that in a few minutes when we get there. So we will be talking about normal changes of memory in aging. There's a lot of confusion sometimes about what's dementia, what's delirium, what's confusion. So we can kind of sort some of that out. But a lot of the problems we create with too many medications. And then how can we affect some of those adverse reactions with medications? So, and I just wanted to put in this slide about brain health. There's a great, there's a link here to a really nice resource about cognitive health and what that means in terms of somebody's capacity to remember, learn, plan, concentrate, and maintain a clear and active mind. And that's basically one of the areas that there is some evidence for dementia. I mean, what we consider an irreversible dementia, that exercise is one of the things that can mitigate the disease to some degree. Okay, it's not going to cure it, but we can actually make things better with health, of course. And of course, that's a passion of mine too, with my swimming. Okay, next slide. Can we go to the next slide? Okay, there we go. I'm going to go back one. I missed that. So normal cognitive ages, changes of aging. There are changes in the brain as we get older. Obviously, you know, there's a trend in our life over time that things get drier, things shrink. You know, we know about women that lose a lot of height, and men do too over their years, because the pieces in between the vertebrae do get less, they have less fluids in them, and we lose height. And that's actually going on in the brain as well. We lose some of the structures, we lose some of the neurochemicals that modulate moods and memory, and we see the results of that over time. But exercise is one of those things that can help. Of course, good health, and we all know what the chronic diseases that we have very prevalent in our state are: diabetes and heart disease, high blood pressure. So learning new things may take a little longer. That doesn't mean you're demented. I think we all notice that as we age. Recall takes a little bit longer. Next slide. So forgetfulness, what's not normal? So serious memory problems that make it hard to do everyday things like driving or shopping, asking the same questions over and over again. I mean, I think there are times that I've done that. You can also have anxiety that intervenes here and looks like that. Getting lost in familiar places, not being able to follow instructions, and becoming very confused about time, people, and places. But again, be aware that anxiety can block that. I'm going to give you just a little quick example of something that I observed very early in my career. Actually, I was a nurse, but I was in graduate school at UCLA. A student came into the locker room, and she was obviously very stressed out, couldn't get her locker open. And she said, I can't remember my combination. And I said, well, when was the last time you opened it? And she said, yesterday. And I said, you know, maybe you just need to take a deep breath. She did, and she went and opened it immediately. So anxiety can really get in the way of performance, regardless of your age or mental status. So that's something to be aware of. Next slide. Mild cognitive impairment, MCI, is a common term that we use in our field. And this means that there's one or more memory problem, thinking problems, and it's worse than other people their age. Okay, so you can keep that in mind. It can be an early sign of Alzheimer's disease, but not everybody with MCI will develop Alzheimer's disease, because we're going to go look and see what else might be going on. This person should be followed by their primary care provider, geriatrics if that's available, or neurologists every 6 to 12 months to track changes in memory and other skills. I'm going to say here, I'm not getting into what the cognitive assessments are. Some of you have probably heard of those. Mini mental state is one that was very popular for many years. We stopped using it years ago. Number one, because it got copyrighted and we didn't want to pay for it. But number two, it's also not all that sensitive. And I had some patients that pointed that out to me, a guy with a PhD, and he scored 30 over 30. And I said, you got a perfect score. And he says, yeah, but I'm having problems. Okay, so we got to really listen to things like that. Okay, next slide. Okay, so the dementia is not a normal part of aging, but it's the loss of cognitive functioning, thinking, remembering, etc. It's generally irreversible and progressive. There's very few exceptions. When we say dementia, we really should be talking about something that's irreversible, but I'll tell you about one of the exceptions on that. And it does not name the etiology of the dementia. And we really want to know the etiology as clearly as possible, because that's going to guide what our interventions will be. Next slide. So there's a lot of types of dementia, and these are the underlying reasons. Some of these are diagnosis, and they need to meet certain criteria because there's no blood test for Alzheimer's. I'll point out first, the one that's in green, normal pressure hydrocephalus, which is characterized by an abnormal gait where the person feels like they've got magnets on their feet, and it's very hard to pick up their feet and walk. Along with that neurological complication, they do have memory problems. And this particular diagnosis, it's caused by a dilation of ventricles in the brain, and it's being dilated, so it's pushing on structures in the brain because there's fluid building up in these ventricles. And if this is identified early enough, it can be 100% reversible. And what they have to do is go in and put a shunt in from the ventricles, and they have a little tube that goes into your peritoneal cavity and just drains the fluid, and your body's able to handle that without a problem. It's not a huge amount of liquid, but in the brain, it doesn't take a lot to make a problem. And the other thing that we see when we talk about traumatic brain injury, there's a lot, that's a whole topic itself, but we also see older adults that in the emergency room. I actually spent my first year and a half at Queens working in the hospital, and sometimes we would be down in the emergency room looking at patients too. And it was really amazing to see somebody come in with a subdural hematoma from a fall. They hit their head, there's bleeding, and it's causing pressure on the brain. And if they get it evacuated, sometimes the neurological changes that we saw before the evacuation can clear up completely, if not significantly. So the ones in red, the brightest one on the left, Huntington's disease, that's in bright red because that one is clearly caused by genetics. Okay, it's in your DNA and it's hereditary. You only need the gene from one parent to be highly likely that you're going to have this disease. And it's a progressively neurologic and mental status decline. And I've had just a few of these, but especially in the state hospitals, we did have a couple of these patients that came later. I mean, then in the beginning, you actually see some behaviors that are difficult and they can actually be violent, but that can be managed with medications. But eventually they become bedbound, and that's usually when we would see them in the long-term care facilities. Alzheimer's disease and frontotemporal dementia, I've got them in red, but not the bright red. Those can be genetic. Most are not. With Alzheimer's disease, it tends to be the early onset Alzheimer's disease that is genetic, and usually genetic testing is done. Frontotemporal dementia, there is one type called Pick's disease that can be familial, fairly rare. And frontotemporal dementia is not the most common thing we see, but important for us to be able to tease out because the approach to them is different. Again, it's an irreversible disease. Some people will, okay, we're talking about frontal lobes and temporal lobes. It can be, most common it's frontal and somewhat temporal. I've had one case where it was really just temporal dementia. It was a very interesting case, but we won't get into that today. Okay. So what are risk factors? Okay, this doesn't mean it's in a, a genetic kind of thing, but just it's related to age. The older we get, the more chance we have of becoming demented. If you have that family history, and it depends. Sometimes, I mean, there's my father had Alzheimer's dementia, and a lot of people have had family members that have had it, but it may not be related. If it's really late onset, it's usually not a genetic issue per se. Like I said, the genetic predisposition is that early onset. Okay, next slide. So what does cause dementia? It's usually, if it's irreversible, there's a variety of etiologies. Alzheimer is the most common dementia, which you're probably aware of. But vascular dementia is also actually very common, and it's often mixed with other types. So, and Alzheimer's and vascular mixed dementia is probably the most common dyad that we see. Stroke victims, if they have a acute stroke, they tend to improve to some degree, but if they have cognitive impairment, they generally don't recover completely. And that may be true for their neurological problems as well. Sometimes they have, but it sometimes will be more isolated in terms of what the impairment is. For example, speech. That's a very common thing that we'll see. They end up walking around, they can swallow, but they have some speech problems, and that can be very frustrating for people. But there's a lot of variation there because it really depends on where the stroke was. I'm going to show you some diagrams later that I think might help you visualize what I'm talking about. Normal pressure hydrocephalus, again, we talked about that, can be resolved 100%. Now, the thing that can happen with these patients, though, is that they may not really be able to report the symptoms well if they've already started developing another type of irreversible dementia, usually Alzheimer's disease. So they really don't report things like a normal person would say, gee, my foot's dragging, what's up with that? We just see them falling maybe, and that it's just because we think they've got other problems going on. Okay, so they need careful assessment. And other causes, again, but where does it happen? So this is basically something all that's going to happen in the brain. There may be other parts of the body affected, but in Alzheimer's, it's essentially in the hippocampus, which is in the brain, in the medial temporal lobe of the brain under the cortical surface. That's where new memories are formed. As the disease progresses, different parts of the brain are affected until, even very familiar family members are no longer recognized. Frontotemporal dementia, I mentioned already in the lobes, the frontal and temporal lobes on the sides. Huntington's is genetic, early onset, usually in their 40s or 50s. There's one infectious disease etiology that we know about, Creutzfeldt-Jakob disease. I don't know that I've ever seen a case of that, but I've read case studies about it. But that's very, very rare. And toxic substances that can cause damage to the brain, excessive alcohol, opioids, benzodiazepines, and methamphetamine. Certainly in the last couple of decades, we've seen what that looks like in the hospital, and really with pretty young people. And that's pretty much a vascular issue that's going on. Benzodiazepines, I did not include that as one of the absolute categories. I'll probably talk about that anyway. I have a short answer about benzodiazepines for the use in the older Americans or older adults, period, is don't use benzodiazepines. They should be used very sparingly, very rarely, and with very close monitoring. These drugs will cause a lot of dysfunction. They can cause habituation. They are actually considered to cause some dementia as well, and it causes personality issues that can be very difficult. And when I have weaned people off of benzodiazepines after long-term care use, which takes a very long time sometimes, it's amazing what can happen. And I had a patient many years ago, but came in with a care home operator on benzodiazepines. The care home operator was actually concerned about that. I think she was aware that this was some kind of an issue. So she was great to work with, We did a very, very, very slow taper. I enlisted a geriatric psychiatrist that we had available. So we were all on board with the plan. And over the next 9 months, she was completely off the benzodiazepines. And in the next year, this patient was able to go back to independent living when she was off the benzodiazepines. Okay. So that's all I'll really say about benzos today, unless there's specific questions later. Next slide, please. So how does it progress? Okay, so initially we start seeing the problems, not everyday living, ADLs are fine, but it becomes problems with managing higher complexity tasks, such as managing your finances, getting the taxes done. That's a very common place to see that, and getting confused about things that they were able to do before. Okay, if you haven't been doing it your whole life, then that's going to be a hard measure to do. The short-term memory is really the thing that stands out initially. It looks like, at first you can kind of start recalling things, but then it's short-term, that you just learned something yesterday and you really got it, but today it's gone. The long-term memory is preserved for a long time, really until the end of these, so that people remember their family members, they remember where they're from, even though they don't know where they are today. So orientation, and it kind of goes in this order, the time right now is the first thing to go, the date. And that's, since I retired, which day of the week is getting a little harder to keep track of. But I do know the month. Season is kind of subjective in Hawaii. And then the year, because it's 12 months of the same year, people tend to get that longer. Seasons, and that's part of some of the standardized testing, at least it used to be in the mini mental state. But I found that was sort of a culturally biased question in Hawaii, where we don't really, well, we do have seasons. I would ask my patients, and when I started doing this work in Hawaii, I was working with a lot of retired plantation workers in their 80s and 90s, and they had about a third grade education. And when I would ask them what the season was, they get this blank look, and they're like, mango season. Okay, well, you know what? I'm going to accept that, because they're right. If it's March, April, May, summer, it's mango season. But so that's just really not a good question here. Orientation, do they know where they are? Very common. My last clinical work in the last 4 years has been in the post-acute rehabilitation setting. And it's extremely common when we get patients out of the hospital, they're still what we call a little delirious. And we're going to talk about what delirium means. But so do you know where you are? You know what the name of this place is? So it's Queens Hospital. Okay, so they're still back in the hospital. They don't realize that they've moved to another place, and they don't know the name. In their activities of daily living, it progresses from the more complex things like, bathing and showering. They can do that for pretty long time. But feeding is usually the last thing. They can feed themselves for a long time, and eventually they need to be fed. Recognition of family members or caregivers, if they have a stable caregiver, they recognize them for a very long time. Language ability declines over time. And then we may be getting behavioral symptoms such as agitation, psychosis, meaning they're either hallucinating or they're thinking. The difference between a hallucination is something they see, or a delusion, which is something they report, but they don't say that they're seeing it. And if you ask them if they're seeing it, they kind of don't answer, or they move away from that. But it's something like, and it's usually somebody's stealing my things. That's the most common delusion, is that somebody's taking money out of their drawer, or they stole their purse. That's a delusion. Hallucinations is something they see, and it's something we don't ask about specifically enough. And it's a very important marker of either a delirium, and which can be from medications, or it's very specific to a couple of disease states, mainly Lewy body dementia is a very common, hallucinations are a very common and prominent feature, usually early in the disease. Now, they may be having it later in the disease, but they don't report it as well. And I've had many patients where I ask them about this, and I'll kind of soften it with saying, as we get older and we're taking medications, sometimes we can have problems like seeing things that aren't really there. Has that ever happened to you? And it's almost diagnostic with a Lewy body patient. They'll say, yeah, I do. I see penguins on my bed, and I like my penguins. They're not usually bothered by these hallucinations. I had another lady that saw pink roses in the bathroom all the time. And she seemed kind of relieved, that I was acknowledging that, and it was okay that she saw her pink roses and she liked them. Next slide. What is delirium? And this is a really important thing to differentiate between dementia and delirium, because a lot of times we have people, they might be on the border, but they just might be a lot older. And sometimes it's going to be either, we'll talk about what the reasons are, but we really want to tease out what is going on with them and find out what they can do. They may be disoriented, confused. Again, they can be hallucinating. Usually this is something that starts suddenly, and it's often temporary, and it is treatable. So we don't want to cause looking at a delirium and say, oh, they're demented, because if there's something we can do to mitigate that, even though they may still have a dementia underneath, we want to address that. Next slide, please. So there's 3 types of delirium. I wouldn't take notes on this, but just realize hypoactive delirium means they're not very active. They're less active than usual. They might be sleepy, tired, seem depressed. Whereas a hyperactive delirium is they're restless and agitated. And mixed, of course, we can see things going back and forth, or they can coexist. And I talk a lot in most of my talks, I talk a lot about constipation in older adults, especially demented patients, because it's very common and it causes a lot of problems. And I have did many consults in the hospital with people that were really delirious and wild and trying to rip off restraints and hit and kick people. And really the etiology was constipation. And this happens when they're not eating and drinking well to start with, but they're not very active. They're sedentary, they're not getting up, they've had surgery, they've had anesthesia. And I find fecal impactions that are seriously huge and causing a lot of problems. And it's just amazing what happens when we address constipation. That won't be the last time you heard me say that. Okay, next slide. Other things that cause delirium: alcohol or drugs, of course, dehydration. And along with dehydration, which can be from drugs, right? If we have patients on diuretics, your Lasix, spironolactone, any diuretic can cause dehydration and can cause electrolyte imbalances. We also get electrolyte imbalances very commonly for people that are started on our SSRI antidepressants. And we'll be talking about those a little bit more. But particularly with sodium, that's the big one that drops with the antidepressants. And people that have some lung disease and syndrome, we call syndrome of inappropriate antidiuretic hormone. And we have to restrict the fluids on them. So we really have to be very careful with them. Just being in the hospital, it's very disorienting for a patient with dementia. Any infection, not just Creutzfeldt-Jakob, but delirium can be caused by when they run a fever, high fever. They may very well become delirious. And that's just, the fever has just taken away that last little bit of layer of cognition on the brain, and behaviors emerge. Again, the most common problems are medication. And we'll talk more about that when we get there. Metabolic disorders. So patients with that, especially with kidney disease, your kidneys are the master chemists of the body. So people that have some or a lot of kidney disorder, even patients that are already on dialysis, the drugs and their cognition and current state of diet and hydration may cause problems with this. So again, it's the electrolytes, the potassium, sodium and potassium are the 2 big ones that are modulated that we need to look at. Certain medications, I'm not covering really antihypertensives per se, but when we start somebody on the ACE inhibitors, which is your lisinopril, or ARBs, which is the losartan. We see a lot of losartan. It's a very good drug, but either one of those medications, especially in somebody that already has kidney disease, could cause a retention of potassium and cause big problems, especially cardiac problems. So, and that's where your organ failure comes in as well. Diabetes is another metabolic disorder. When we got really high blood sugars, things are not going to be working right, and they can look pretty bad. Poisoning, of course, I mean, including medications, but it could be other substances, including alcohol. Just a serious illness, severe pain, and then you add on opioids, which they may really need for their severe pain, but they may look very delirious if they don't sleep well. But we'll talk more about sleep too. Anesthesia is well known as a inducer of delirium in older adults. And if you still have patients on Aricept, donepezil is the generic name, a lot of people don't know, including the physicians, that that drug should be stopped for 2 weeks prior to surgery. A lot of times it's, you don't know they're going to have surgery, but when we know they're going to be having surgery, if anybody can be on the outlook for that. Obstructive sleep apnea. I don't think we have the final word on this, but it seems like more and more it actually can cause dementia, but certainly we see delirium. And I've seen this recently, real common for these patients coming out of the hospital. They didn't have their sleep apnea, their CPAP with them in the hospital. And for some reason, it still doesn't come. We have to really bird dog this to get somebody to bring in their equipment, because they do look very delirious. It's a hypodelirium usually. And you think this person looks really demented, and you can't finally get their CPAP going. And it's like, wow, and I do the testing with them. It's like, they're fine. It's just, they really need to have that apparatus. So that's something we can be clear about when we see people coming out of the hospital. And if they look really delirious when they get home because they haven't been using it, then think about that. Next slide, please. So it's just another way to look at altered mental status and deliriums. We talked already about stroke, infections, the subdural hematoma, normal pressure hydrocephalus. The Wernicke's encephalopathy is an altered mental status that's related to severe alcohol, long-term use of severe alcohol, and does cause changes in the brain. A non-convulsive status epilepticus, that can also cause altered mental status, and that's a hard one to pick up, but that's why these people need to be evaluated. And if the PCP, and it's really hard for the PCP to do all of this themselves, but getting a specialist involved. And then there's hypertensive encephalopathy. So people that are running really high blood pressures may look delirious as well. And then, in red, the medications, because that's what we're going to be talking more about. And that's such a modifiable risk factor that we never want to miss that. Next slide. So changes in alertness, we've kind of gone over this already, but especially in the morning, the delirium might be worse, maybe because of how they're sleeping and maybe having some decreased ventilation. They don't know where they are. Their thinking is disorganized. They really can't stay focused. And that's a really important concept with delirium. You cannot diagnose dementia in the presence of a delirium. So if they can't pay attention, and the way we look at that, and the variety, all the mental status exams have some way to look at that and to repeat the series of numbers. And I have pretty demented people, if they're not delirious, they can still repeat back at least 5 numbers. So 7, 8, 3, 5, 4, and they can do that. Now, when I ask them to do it backwards, they have a much harder time, but they can probably do 3 and they can do the task. We also do letters, and I'm going to read this long list of letters, and I want you to tap. Usually I have them put on my knee so I can feel it when they hear the letter A. And if they're paying attention, they can do that if you don't go too fast. So we can see all kinds of emotional changes. Again, the hallucinations and delusions. You might see incontinence that is new, and concentration and memory problems. And I'm going to be talking, the incontinence is going to come back to a whole nother issue when we talk about antibiotics, but incontinence is often thought of as a symptom of infection, right? No. I mean, it might happen, but that's not part of the criteria for a urinary tract infection in the elderly when there's a change in their cognition. And because it might be, if it's brand new, that might be a different story. Or there's a increased urinary incontinence from baseline. So those are finer details. Concentration and memory problems. And again, that's the biggest area. If they can't concentrate, that's a delirium. That's not the dementia. You can't say anything else about the dementia until you investigate the delirium. Okay, next slide. So this is just another way to look at what's the difference between delirium and dementia. So the delirium, sudden onset, reversible, disoriented onset, waxing and waning, poor concentration, poor orientation, immediate memory is poor, disorganized thinking. But in the dementia, it's gradual, stable. Short-term memory is really one of the earlier signs after their ADLs. It's persistent. And the long-term memory is the last thing. Okay, next slide. And the other thing we don't want to miss is depression. It can look like a delirium. It can look like dementia. So depression, we're saying within 6 months. I mean, sometimes it's been missed for longer than that, but when you get the history, yeah, it's been the last 6 months, not just in the last couple of days. Then we're really looking for delirium. Whereas dementia is a very insidious onset. Depression can be fluctuating. In dementia, it's usually a stable cognitive loss, unless they're having lots of little strokes. Then you might see things dropping off very precipitously, and maybe they get a little bit better, or it stabilizes, and then you see it again. So then that's when we're really wondering about, the vascular dementia. And I'm going to speak more about that too. Again, depression, again, poor concentration. So we've got someone with poor concentration, you're looking at delirium or depression, not the dementia. And they'll highlight, with depression, they'll highlight their disabilities. Yeah, see, I can't do it. You ask them different questions. Whereas the dementia patient is like, did I get it right? Did I get it right? They really want to perform well. So that's a big differentiation you'll see over and over again. With depression, they'll be, I just don't know. And you'll see the depressed mood. But you can have an agitation in dementia. And that is something we don't want to just, they're demented and they're getting agitated. It's really common in depressed patients, and we don't want them mistaken for being demented for that. Next slide. Okay, so how is this diagnosed? And I know you're not going to be doing the diagnosis, but I find this can be very helpful for families and caregivers to understand the disease, is to know what it is we do. And this was a project I did, not this one particular one, but when I did a Kaiser, when I worked there, we did a 6-region post-dementia diagnosis program. And we tested things, and one of the things I did was establish educational session for caregivers and family members once they got this diagnosis. And they thought it was very helpful. So it's the history of the symptoms and the behaviors is very key. It's a full physical exam, particularly neurological and cognitive assessments. I won't go into all the details of that, but it's not something you can just glean from the chart. It's really with the patient. We will be looking into the chart. I'll talk about that. We want to know the functional assessment. So that's partly from the history. And I mean, sometimes we will have therapists involved with that. There's a variety of blood tests we're going to be looking at, making sure we're looking at electrolytes. There's not a thyroid disorder, which can be either hypothyroid or hyperthyroid. We also have the parathyroid. If you have hyperparathyroidism, these people can look really nuts. I mean, the behavior is very confusing. So we always check both the we always do TSH, that's thyroid stimulating hormone. We usually only do the T4 if the thyroid test was indicated the TSH was very low, which means the TSH might be very high, and that may be something, and we'll be checking calcium. So the calciums can go very high and cause great mental status disturbances. And some of these people really need to be hospitalized. They need drugs, they need hydration, and close monitoring on that. We're going to talk about the medications and ruling out other pathologies. Now, you see here on the upper right-hand side is a clock drawing. That's part of pretty much all the cognitive tests, and very important. And what you see here, what we're telling the patient to do is, I'm going to ask you to draw the face of a clock. First, draw the circle, and then put all the numbers in, like the face of the clock, and set the hands at 10 past 11. And they can ask questions along the way if they forget. And what you see here is everything is on the right side, and there is nothing on the left side. And I would still go and do a chart review, because I'm pretty darn sure if we don't have it, I'm going to look for, and fortunately with our electronic medical records, the Kaiser, Queens, Hawaii Pacific Health, University of Hawaii, a few others, we're all on a shared platform with the Epic electronic record. And if I find a CAT scan, which is fine, we don't need an MRI. The most important thing to do right away with a stroke is a CAT scan. And even our neighbor islands can do a CAT scan. And I'm pretty sure this is a right middle cerebral artery stroke. And they have a left hemiparesis and the syndrome of neglect. And so these people really have big challenges. And these are people that initially, they think they can stand up, and they might be able to stand up, but they can't walk. They think they can walk. So the neglect syndrome with that happens is they just, even though they can actually see on the left side, they're not blind usually. I mean, you have to check that. But it's a neglect syndrome, and they just don't pay attention to it. And these are the people, you have to put all their food on the right side of the tray, because if you put it on the left side, they're not going to eat anything there. You can almost do that. And I did a family conference on a patient that had a stroke like this at one of the facilities, one of the state facilities. And the family was bringing a friend who was a ICU nurse, and they wanted to know if they had a MRI scan, and is that something we were going to do? And we went through the what the findings were, what we had found in the records, and then I showed them this clock drawing. And the nurse that had come with them, he said, "Well, there's the CAT scan. We don't need to do a CAT scan. It's very clear what the diagnosis is." And and we did find there was a CAT scan, and we didn't need to do an MRI either. So very interesting. There's one more. Advance it once, because I think I have another drawing in there. So I have a whole bunch of these, but I didn't want to bore you with too long on these. So you see the little thing up in the upper right-hand corner. What's that? Oh, that's the face. Sometimes they're interpreting things differently. And you'll notice, though, the numbers go all around the clock, but they're backwards. So again, this could be, I wouldn't say this is not a localized stroke, but it's probably some kind of stroke. Or, strokes can be hemorrhagic or embolic. Embolic meaning it's one place. Like the last slide with the clock, I said, oh, it's probably a middle cerebral artery occlusion. That's an embolic stroke. But if you have bleeding strokes, it's very hard to predict what the deficits will be. So you have to look at, neuromotor things, speech, swallowing, and those are the main things. And vision problems can occur in all of those too. Okay, next slide. There we go. So I already talked about most of these, and I'll bring up the vitamin deficiencies. I don't want to go into all vitamin stuff. I just want to make sure you know that, yes, we do check certain vitamins for dementia workups, always a vitamin B12, and more often than not, a vitamin D is very common. Well, we used to think, oh, in Hawaii, a lot of sun people aren't going to be vitamin D deficient. Even if they're out in the sun, that's not true. There are a lot of vitamin D deficiencies out there. It has become even more prevalent knowledge recently, and I think we're going to see more work on this. And some of the vitamin deficiencies can be related to medications, particularly for vitamin B12. If you take metformin, which is metformin is a great drug for diabetes. If a type 2 diabetic can take metformin, because their renal function can handle it, we still love metformin, unless they're really losing a lot of weight, but it does help with weight loss, and it lowers blood sugar, and it, in general, the vast majority of the time, it does not cause hypoglycemia. So we're not causing people to be faint with low blood sugar when we use metformin, but it can cause vitamin B12 deficiency, and that can be a problem for a lot of metabolic issues, including cognition. The other drug that can cause problems for vitamin B12 are all of your proton pump inhibitors, things like Prilosec, omeprazole, esomeprazole, and sulprazole. Though that needs to be paid attention to. And that is one people can just take because it is water soluble. B12 is water soluble. All the B vitamins are, and you're not going to cause an overdose. However, I want to be very clear that, be very careful about just buying a lot of supplements. There's a lot of things on the market. And if you look up any of these things on the internet, usually the first, it depends on your computer, how things are set up, but it's all ad stuff. And there's just, I'm just going to call it spade a spade. There's a lot of snake oil out there, and you can spend a whole lot of money on snake oil when it would be better spent on other things for this person in their food. But always discuss all of these supplement things with the primary care physician that knows, or nurse practitioner that knows this patient. And sometimes they're not, some of the finer details of things, they might want some help from some of the specialists. But those are the two main things: vitamin B12 and vitamin D. And again, mostly going to be medication side effects, depression, thyroid disorders. Tumors can be, that's pretty rare, but it does happen. And that can be a very difficult call. If we just do scans without really thinking through the process of really, where is this person? It shouldn't be a knee reflex thing to start doing head scans immediately, because you may come up with incidental findings, and then you're stuck, oh, they got a meningioma. And I've seen it more than once. Oh, we found a meningioma, because we're doing CAT scans on everybody, and it's really not always a good idea. And we go, and the neurosurgeons love to take out meningiomas, and some people do really well, but a lot of our patients don't. And we've actually done more harm than good. Yeah, and let's go on to the next slide. Oh, wait, let me see. Okay, some of the questions are starting to come in. There we go. Okay, so we're going to get to the medications now. This will be the majority of what we're going to talk about today. And I know we'll have lots of questions, so I want to move on with that. So the PIMS, potentially inappropriate medications in older adults. This is part of the evidence-based document by the American Geriatric Society called the Beers criteria. It's updated every 3 years, and it was last updated in 2019. It's called the Beers criteria, not because we're going to use any kind of beer, but the Dr. Mark Beers was the physician that started this. He was at UCLA when I was there. And shortly, I didn't actually have much interaction with him there, but later there was a conference in Los Angeles that I went to, and he was the speaker for that. It was very interesting. And I got to speak with him offline. So that was kind of exciting, and really kept me in touch with what they were doing on this. But over time, and he actually died quite young. I think he was in his 50s. He was a diabetic, type 1 diabetic. So the American Geriatric Society took over on the Beers criteria, and it's just grown and grown and grown. The document's quite extensive, and there's no way we could cover all of it. But they talk about what polypharmacy is the use of 5 or more medications, which is likely to precipitate adverse drug reactions. And we have a lot of people out there on more than 5 drugs, right? Okay, next slide. So it's not just taking too many medications. If you're taking the wrong dose of a drug, that's polypharmacy, because it may be causing problems. On the flip side of that, if you're taking too little of what you need, that's a problem too. And that's really true with some of our cardiac drugs, right? We want to start low on everything. That's a mantra we have in geriatrics is start low and go slow, but you got to go. So drugs that are not needed, including vitamin or other supplements. And I know the question will come up about ginkgo biloba. No evidence. That has been on the table for years and years. We really have no good evidence for that drug. I know there's a lot. If you just go to Costco, you'll see all these things. And I just looked at those recently as I was thinking about this program. And, this stuff is not cheap. So you really want to be careful about that. And the ones they have at Costco are not terrible. Well, ginkgo biloba is not shown to be efficacious at all, but also on the internet. And I know there's things coming up on Facebook too. And there's physicians that, they do these podcasts like for a half hour, an hour, and they go on, and they really explain these things really well. It sounds great. But they've got the answer, and it's nobody else has got it. And I would just steer clear of all of that stuff. It's really just snake oil. Okay. They do not quote, they tell you all these things, but they never give you the literature that supports their claims. So that's a red flag. Okay. And then drugs that inactivate each other. My most famous example of that is Aricept or donepezil, which is for Alzheimer's disease, which, I think probably the best thing about Aricept was it was the first drug, and we got it in the late 90s. And it was the first drug that could do anything for Alzheimer's disease. And what it did is it really brought people in. It was really kind of made it, enabled geriatrics to be a more recognized specialty, and people would make referrals because they didn't know about this drug. So maybe geriatrics can help us with that. And we did. But really what we were doing is helping the patient and the family through the journey. Okay. And the medications are really the least of the benefit. It's really understanding the disease and all these things that we're talking about in polypharmacy. And then how do you deal with driving, toward as they get worse. But if they do take Aricept and then they use overactive bladder drugs or other anticholinergic drugs, you're wasting your money on both because you just canceled them both out. I will be talking about that a little bit more when we talk about our anticholinergic drugs, which is the main show. All right, next slide. So the outcomes of polypharmacy, it's big. It's not just the cost of the unnecessary drugs, which is a cost to you because most of this stuff is not covered. But then the cost of treating the adverse outcomes. Lots of falls with fractures, bleeding in the head, so you get your subdural hematomas. If not worse than that, gastrointestinal bleeding, kidney failure, and heart failure. And those are our very real things that we see in the hospital. And should put the big delirium over there because when I worked in the hospital, that's what I was doing. I was seeing patients with delirium all the time. And lots of big problems there. It's also increased indirect costs with placements because you have to place them sometimes. They're going to be, everybody thinks the nursing home is covered when you come out of the hospital, and it generally is. But you got to have a underlying reason that you can do some rehabilitation for. And it still, during the pandemic, they suspended the 3-day requirement because we wanted to get people out of the hospital as fast as possible. But generally that's the rule, 3-day acute stay, and then up to 100 days. People think it's 100 days no matter what. No, it's only as they are making progress towards their baseline, okay? We don't make people better than their baseline on their Medicare benefits. And then quality of life, of course, is an issue. And we all need to be mindful about lawsuits if we do things that are not evidence-based and efficacious. Next slide. Okay, antihistamines, which is part of this group of anticholinergic drugs. And these are the side effects that cause many problems with the dry mouth, lots of confusion. And with the dryness, constipation, which causes a whole nother set of problems, as you are probably well aware, urinary retention, which may be totally neurochemical because of the drug's action or because of the constipation. And you especially see that in men, that especially if they have an enlarged prostate. Oh, and they're not taking the drugs that they need for that anyway, but that's probably appropriate at that time. The hallmark drug of this class of drugs that are anticholinergic is Benadryl or diphenhydramine. So people talk about Tylenol PM, and all they see is the Tylenol. It's just like super Tylenol. No, it's Tylenol plus diphenhydramine. Or people just see the Benadryl and they think Benadryl is good. You know what? Benadryl, it can be a life-saving drug. And this is one over-the-counter drug that has problems that I agree, it should be over-the-counter. And I think the Tylenol PM, I think the best use of Tylenol PM is for my colleagues that I do open ocean swimming with, and they get stung by a box jellyfish. It can be a life-saving drug. I have several people that I have looked, there's a box jellyfish. They get stung, they come out of the water, and they tell me, saying, I don't feel good, you know. And I had one guy that had been through chemotherapy, and he was out of the woods on that, but he said his kidneys hurt, his teeth hurt, and he just felt terrible. And I picked some people out and I said, you're taking them to the hospital. And we had a couple that, you know, came together. So one took his car, and I gave him Benadryl. I put some hot water, vinegar. I didn't have vinegar at the time, but hot water, and gave him a Benadryl. Just the Benadryl. It wasn't the Tylenol PM, but Tylenol PM has Tylenol on it, so that would have been good too. But anyway, they got to the hospital. He said by the time he checked in, he felt much better. And this has happened several times. Interestingly, I have seemingly never been stung by a box jellyfish, which is hard to believe. But anyway, we do wear a lot more clothing in the ocean these days because of the increasing box jellyfish. All right, so people think this is a good sleeping pill. This is not something we should be using in the elderly, period. Okay. The next slide. So, but we don't want to toss out the Benadryl. It should be used for people that are having allergic reactions. Actually, we had another lady, I don't know what was going on with her, but said, looks like allergic reaction. She said, oh yeah, and I took the Benadryl the other day and it really helped. It's like, so do you have your Benadryl? No. So I gave her some. And with all the, you know, cautions about, you know, don't be driving when you're doing this. And that's why when I give it to them, I say, wait, someone else has to drive them. So it is good it can be really life-saving for people. And it really, and we had an emergency room visit, but they just discharged him. But people have been in very serious trouble with the box jellyfish. Rarely. Okay. But, you know, if you're going to use, if you want to take, my favorite sleeping pill to give somebody that has any kind of reason for pain is give them some Tylenol, give them 500 milligrams, even 650 milligrams. It may promote sleep because you've addressed the pain. Anyway, that's good for that. Go next slide. We've got some more antihistamines. So, then as I was, you know, looking into some of this, like, oh, so is Advil PM better than Tylenol PM? Well, no, you still got it still has diphenhydramine in it. That is the thing that is making it make you sleep. And it does make you sleep, but the side effects, really, there's better ways to handle sleep. And I would say sleep hygiene is probably the most important. But especially for older adults, we do not want to be throwing non-steroidal anti-inflammatories at them. So the Advil is naproxen. The most common one we see is it's lost ibuprofen, right? So it comes in brand names. Motrin is the brand name, ibuprofen. All of these drugs can be problematic with older adults, kidney problems, and raising blood pressure. So, and even younger adults, and we've seen adults in their 40s and 50s, you know, just trying to deal with some injuries, and they keep taking Advil or ibuprofen, whatever it is. And we've actually seen people go into kidney failure on dialysis. So this is a really serious issue to take up with anybody that you know, if they're using these things that are not really monitored well. It can also, and then the high blood pressure can also cause cardiac problems eventually, right? And the NSAIDs also are very well known to cause erosion or GI bleeding. That, you know, causes stomach, can cause an ulcer and GI bleeding, and that can be very dangerous and uncomfortable. So Tylenol PM is probably safer than Advil PM in the long run, but I'm sure there are some situations where people that don't use it very often, it's probably okay, but I don't advocate for that. All right, next. So another antihistamine on the market, and all of these people also use for seasonal allergies, but primarily Zyrtec and Allegra, cetirizine and fexofenadine. They're fairly non-sedating, especially cetirizine. That's probably the least sedating. So I usually will go to that one for older adults that do need some kind of allergy relief. I don't know if it's sedating. It's pretty non-sedating, but it might be okay. I mean, again, if the symptoms are what's affecting them for sleep, then that might be okay. Atarax is over the counter now. All of these are over the counter. It used to be prescription. And you know, it's not as bad as diphenhydramine in terms of its anticholinergic effects, but it's still anticholinergic. So I would be cautious with that one too, but it is a little safer. Next slide. So still on the anticholinergic kit after menopause with vaginal estrogen. Well, so an alternative to the overactive bladder medications is, with careful evaluation, vaginal estrogen can help, but I would say that needs to be monitored closely. I have seen a situation where you know, we don't really know what the application strategy was at home or in a facility. I've seen it happen in both places, and there was bleeding. And so with vaginal bleeding, that can become a problem. People get very upset when there's bleeding, and for good reasons. And actually, I do recall in one of these situations in my career, fortunately, I did not prescribe it, but there was repercussions for the physician legally on that decision without, you know, close monitoring. That's all I'm going to say about that one right now. Okay, so the medications for overactive bladder are primarily anticholinergic. The latest one, the Myrbetrag, probably is the least anticholinergic. The older ones like Detrol is the most common one, very anticholinergic, and I would definitely want to stay away with those. They don't have to be demented to have some mental status problems with it that I've seen. Next slide. Okay. And I'll move on. So I'm not going to read all of these to you. These are just some of the medications. I guess you're going to be getting a copy of this, but again, overactive bladder medications, these are anticholinergic problems: dry mouth, constipation, drowsiness, memory problems, urinary retention, increased risk of falls. We talked about all of those. So let's go on to the next slide. Hopefully you're not seeing this anymore, but every once in a while it pops up. The older antidepressants that are called tricyclic antidepressants, also very anticholinergic, same issues, totally. You do still see paroxetine sometimes. It's newer than most of the other ones. It also is anticholinergic, and it's we tend to not use that one in geriatrics. Bupropion is not anticholinergic per se, but it should be used with caution due to lower seizure threshold, and generally dosing, you know, it's independent for the person, but it needs to be gradual when you're titrating up, and you need to titrate down for most of these. Wean them gradually. Next slide. Okay, here's the more commonly used antidepressants. SSRI stands for selective serotonin reuptake inhibitors. Citalopram, escitalopram, they're preferred agents in older adults. Very little sedation with these, and they're quite helpful with anxiety as well. We do need to check EKGs just about for any of the antidepressants. We can be causing cardiac problems if we don't look at that. And we need to check electrolytes, sodium. These drugs can drop sodium very quickly. So we usually check within the first week, definitely 2 weeks for those. And then I would be very cautious about using Prozac. It's very anorexic, and that's commonly a problem in the elders. And I'll get into a little bit more about that drug in a couple of minutes on a case study. Next. Then we have another class called serotonin norepinephrine reuptake inhibitors, or SNRIs, and that's things like venlafaxine, duloxetine, which is Cymbalta, and those, and there's a couple other new ones now too. These drugs initially were just for depression, but I tried at the begging of a patient with fibromyalgia. I took a shot at using the Cymbalta, duloxetine, and she came back the next month and said, "It's a miracle. You gave me my life back." I was like, "Wow, good. You don't need to come back." I was leaving Kaiser at the time, but and it helps with, they help with neuropathic pain. So that's the mechanism probably for the fibromyalgia. But I also had other patients with pain syndromes, and we use them a lot as an adjunct to pain syndromes. We used to use more of this gabapentin, but gabapentin is pretty sedating. So, and it's hard to dose, you know, it's 3 times, it really has to be 3 times a day eventually. With these drugs, it's once a day. So very good. Someone might ask about Lyrica. It is also good for neuropathic pain, but it's not really an antidepressant. It does seem to be helpful with anxiety. So, but it's controlled. So there's just you have to just look at the particular patient and see what, you know, where we're going to go with that. Next slide. Again, everybody's got side effects we need to look for. But again, if you do it slowly and you titrate it slowly, you tend to decrease these adverse side effects. Next slide. So Remeron is totally different. It's a tetracyclic antidepressant. It works on the central nervous system, and it's a very good antidepressant. It tends to be somewhat sedating, so a lot of people use it at night, and that's appropriate. That's where you should start. However, if we increase the dose, usually around 22.5 milligrams, and certainly 30 milligrams, they may start becoming activated. The norepinephrine starts to kick in, and you don't need to stop the medication, but you can adjust it and start giving it in the morning. Okay, next slide. Mirtazapine has been shown to increase appetite in a lot of our patients. So we actually, if we've got someone that's losing weight with their depression, then we might opt for the mirtazapine, and it's sedating, so we might use it at night. Okay, it's not an appetite stimulant, and you're going to hear me talk about that a little bit more next. Prozac is one of the SSRI antidepressants. It's one of the first, and it was really great for its time. Still has use in many adults, but it's very anorexic. And again, I told you that I'd like to steer away with it. I had a patient that I saw at home one time. I was seeing for somebody else, and she was on Prozac and she was on warfarin. And I started thinking about this. Well, what's going on here? Well, she took the Prozac and she became anorexic and was losing weight. So her doctor prescribed, guess what? The drug that stimulates appetite that we use, Megace or Megestrol, which has been shown to work in cancer patients, younger cancer patients, has never been shown to work in older adults. And the risk of embolic events is very high, and we've seen it. And that's what happened to this patient. So she took Prozac, losing weight, then she took the Megace, then she had a blood clot, then she was put on warfarin. So now I've got this patient on all three of these drugs, and I'm trying to tease it out. And I did talk to the PCP, and she was very embarrassed about it. She didn't know that. So be on the lookout for those kinds of things. We do not, that's one of the big reasons we don't use Megace, and it really doesn't work. And we need to look at everything else that's going on. Take away all the stuff that's making them not eat. So it's a potentially inappropriate medication in older adults, the Prozac. Next slide. And we need to be aware if we are at high doses, serotonin syndrome, which includes all these symptoms that you see: anxiety, confusion, agitation, tremors, lack of coordination, major changes in blood pressure and rapid heart rate, which can be life-threatening. They need immediate medical attention. And that's why we don't want people, St. John's wort is known to increase the risk of this syndrome, okay? So again, an over-the-counter additive that we don't need. Next slide. So I kind of talked about this already, the acetylcholinesterase inhibitors, which is, we talked about Aricept, but there's also galantamine and rivastigmine. And they're still fine to use. The rivastigmine used to have a lot of GI problems. So they switch it to patch, and it really works pretty well. And it's not going to, it might slow the disease, but what we have seen is improvement in some of the behaviors. And so we often will try that. Whereas we used to avoid rivastigmine all the time. Side effects we need to be aware of, but we're going to go ahead and I think we're getting slow on our time. Next slide. And again, if you're taking these drugs, so it's the way that Aricept works is it's blocking. So one of the most important neurochemicals for memory is acetylcholine. And what Aricept does is it goes and destroys the enzyme that's going and eating up the acetylcholine. So it's related to anticholinergic medication. And if you take Aricept and then you add an anticholinergic drug like your antihistamines, Benadryl, Atarax, any of those, you've just spent all this money on drugs that you've just erased everything. Okay, so that's a drug interaction that we would like people to be aware of. Next slide. Okay, I talked about mirtazapine and appetite already. Again, Megace should not be used for older adults according to the Beers criteria. I'm not going to hammer that anymore because of that risk of blood clots and not being efficacious. Okay, next slide. Sedative hypnotics. We should not be using sleeping pills. Look at the underlying cause. Is it anxiety, depression, caffeine, alcohol, pain? Okay, and computers. And I think a lot of us understand that, right? We're going to jump on our phone a little bit more before we go to bed. And next thing you know, it's late. So, and realize that sleep patterns change with age. And I know people really have a hard time with this. They want to sleep like a baby, and that's just not happening anymore for us as we get older. But the more important thing to do is bedtime rituals, right? Set a bedtime. And before you go to bed, start, turn off the TV, maybe drink some warm tea. And well, I'm going to have to go pee. Well, do it a little bit earlier. But these rituals really can be very helpful. Sometimes a Tylenol, if there's really a pain issue going on. But sleeping pills can cause change in the quality of your sleep, can cause falls, mentation problems. Melatonin is probably okay, but I know you guys are going to hear from Dr. Brett Liu pretty soon. And he says on the melatonin, keep it low. Don't increase the doses. 1 or 3 milligrams is probably acceptable. And it might be that it's just part of the ritual, and that's okay if it doesn't do harm. So don't keep increasing the dose on these things. Next slide. Antibiotics, believe it or not. Yes, there are some that can cause confusion. And if they're really sick in the hospital and fevers, and they're wild and they're giving them antipsychotics, you can really see terrible things happening, which I have seen. But the top ones on my list to watch out for are the nitrofurantoin, which is Nitrobid, Cipro, which is not only can be causing confusion, but other CNS side effects and tendon rupture, which is rare, but that's really terrible. And sulfa, not so much the confusion, but it can really worsen renal function and cause hyperkalemia, which can lead to cardiac problems. Next slide. And are we doing our polling questions now?
You can just read your questions and the correct answers here.
Okay.
Valisa.
So Benadryl is a good sleeping pill to use for older adults. False. Next question. Tylenol PM is a safe drug to use for older adults. True or false? That's false. Number 3, antibiotics can cause confusion in older adults. True or false? That's true. Depression in older adults is a common cause of agitation and can be mistaken for dementia. True or false? That is true. Very important point. Appetite stimulants are a safe and effective way to improve appetite in an older adult losing weight. True or false? That's false. So why is it a problem? And how are we doing on time? We got a few more minutes?
Yes, if you can stay late to answer questions, because
Okay.
we have 30 questions already.
Okay, all right. Let's see if there's any repeats here. I'll go through these a little quicker. All right, next slide. We've already talked about some of this. We can go to the next slide now. The adverse side effects, and then the resultant falls and fractures and drug interactions and anorexia, weight loss, blood clots. And one of the worst I see on this list is pulmonary fibrosis. And nitrobit is one that can cause that. There's some others, but that's probably the most common one. It's rare, but worth mentioning. Next slide. Next slide. There we go. Okay. Yeah. So again, increased healthcare costs and indirect costs, the other indirect costs, we talked about that earlier. Next slide. Here's another reference I'd like you to be aware of, the Choosing Wisely program, especially from the American Geriatrics. But this was developed by the American Board of Internal Medicine several years ago. And they had these different groups, including AGS and all different groups, come up with, first it was 5 things. What are the 5 things that people should be aware of? And then now there's part 2. And this is an excellent resource to look at. We won't go over those today. Next slide. And medication reconciliation. I've been in the homes. I've done a lot of home visits in my career. And it's amazing what you see when you go into the home. And I remember one guy that we saw, they had some of them in the living room where those were the ones he was taking the most. And I went to the bathroom and I noticed there was a lot of medications in there. I asked about other areas. There were some in the bedroom, and in the kitchen were his pain medicines. And there were 13 different PRN medications in the cupboard. Do you think that's a risk for polypharmacy and adverse outcomes? Yeah, and probably a lot were expired. So that's where those of you on the ground can really be helping at looking at what's going on at home with these medications. And you can offer to help them. Say, gee, would you like me to take these to the pharmacy? And but probably need to check with your pharmacies if they're doing the disposals. But a lot of reasons people they don't know what to do with them, and we don't want them just to flush them down the toilet. But there's a lot of programs going on for that. So if you can help with that, that would be good. And usually it's like, who knows what they're doing, and nobody's really monitoring that. And these people aren't doing well. So be aware for that. And when you go to and making a list of what they're actually taking and how much they're taking, and be patient with your providers. And you're going to go in, usually some places you're going to be talking to a medical assistant first, and they're going to ask you these questions, and they're going to ask you this. And even though she's looking at the list, they do not know what you're taking at home. You might have gotten things from outside. It's not on the computer. It's, sometimes things from the hospital are still on the list someplace. Sometimes the lists are hard to follow, especially, in the big systems. It's not always apparent. So please be patient and diligent about letting the provider know at each and every visit, what are they taking, and just bring in everything they're taking, and they can look at it too. Next slide. We talked about this a bit already. Vitamin deficiencies are common, especially those vitamin B and D. Some of the folic acid should rarely, if you see a folic acid deficiency in Hawaii, they're either eating no vegetables or they're alcoholic. Okay, so that's going to be my spiel on that. You don't usually need to take them unless there's a reason for it. And we do check a lot of these things in older patients, those vitamin B12s, folic acid, and vitamin D. Don't start supplements before you check with the provider. And again, look at those medications for the stomach, that's for GERD, reflux, that can induce certain vitamin deficiencies, and metformin can cause vitamin B12 deficiencies. Next slide.